Okay, folks. Well, again, thank you for joining us today. We're going to talk directly speaking to how to tell if my loved one, or if it's you yourself, is dealing with a swallowing issue. I'm John Dean. I'm a speech language pathologist. I'm joined here by Josefa, and we're working in partnership with the Inova Parkinson's and Movement Disorders Center. We're so glad to keep working with them. And yep, there's Sonia right there. Hello. And again, we were talking before we got on camera about how we had so many responses to the survey, and we're just going to use that to really draw into the questions that you had so we can answer them in today's session. We're going to talk about three different areas. We're going to have a discussion about the impact of swallowing problems in Parkinson's. We'll have a discussion about how to identify swallowing issues, maybe early warning signs or other indicators, and then a little bit about how it's typically managed. Okay, so we'll start with the impact. When you look at the research and you pull up the PubMed and you pull the articles there, you see a lot of variability in the incidence, how often swallowing problems occur. And I'll say, as a speech language pathologist, they're pretty common. You see them quite frequently. But if you go into the research, I mean, it ranges from as low as 11% and as high as 87%. And that really has to do with the way we do research. It's nothing about what's accurate or not accurate. It's just there are different definitions of what a swallow is or what an abnormal swallow is. A lot of those studies are relying on people either reporting a swallowing problem themselves, which we also did today, or maybe a bedside swallow, meaning I'm just a therapist looking at things. And it's not until you really use an instrumental exam, like a modified barium swallow study or fees with the camera, that you can really identify it. So that means that I wouldn't really focus on what the science says about it and be more focused on whether you're being impacted by it. And the implications of that impact are pretty serious, because if you have a swallowing problem that you don't address with Parkinson's, it can lead to pneumonia or other kinds of infections, and those are very serious. They can cause a lot of issues. You can have weight loss, unintended weight loss, but a weight loss nonetheless, and malnutrition. And these are all pretty serious. If you're not getting enough calories in, it's going to have a huge influence on your quality of life and your health. But also, if you don't have enough weight and you have a fall, you're going to have a higher risk of injury. So you want to be really aggressive about addressing swallowing problems in Parkinson's. Now, when we took it to people and asked them in the survey how many people identified a change in themselves or in their loved one, about 6 out of 10 said yes, for sure. And another almost 15%, so we're getting to 3/4, said they're not sure, which means maybe there's something they're seeing, but they can't quite tell. And that tracks pretty closely to the research. And I'd even say maybe a little bit lower, but that's okay. I mean, I think people being aware of it themselves is a good start, and we're going to help you with that as we go through the slides today. Now, drawing directly from the survey, we get a lot of responses that really kind of caught our attention. People saying, I don't really know how to help, or it scares me. A couple of times people were talking about social situations. So he is a social person who's now reluctant to eat in public due to difficulty eating and the length of time that it takes to eat. Or I have to cut back on activities that include eating. That has a big implications for the social engagement and being able to be with your friends and family the way you want to. And then even things like, spits all the time and makes a mess, that can make you pretty reluctant to go out in public. And then this other one over here in the corner, this is the one that caught my attention, because when it happens, he always has an answer for why it happened. And that really speaks to maybe a lack of awareness. We really want to get to that awareness, because Parkinson's itself happens slowly over time. Some of the issues, like the swallowing problems, happen slowly over time, and you may not really notice them happening until you have some kind of event that precipitates you going to the doctor. So to get to the next part, let's talk about how to identify the problem. And what we're going to do is we're going to make a checklist a little bit for us to walk through. And we'll go through some of the most common things, and then maybe some of the less common things. And we're trying to get you and your loved ones attuned to how to identify what could be a swallowing problem, so you can go to your doctor and get a referral and address it. Now, probably the most common thing we saw on the survey, we saw dozens of these answers, were people talking about coughing, or they would say choking quite frequently, but coughing, choking when they're drinking liquids or when they're eating food. And it could also just be with your own saliva. That's often very, very common. And typically what will happen is a little bit of liquid or something will get past your body's natural defenses and get into the part above the airway, so this area above the vocal folds, and irritate it. You have a system there to protect your airway, and it gets irritated and you start coughing and clearing your throat, and you can tell that there's a problem, and so your body goes into its natural response to address that. And so this is probably the most common indication. And certainly we all have a situation where once in a while, water goes down the wrong pipe and you're coughing a little bit, particularly if you're not quite paying attention to what you're doing or you have a distraction. And while that could happen to anybody, if it happens more than even like once a week, I think that's a good indication that there's something going on that you want to address.
Yeah, I wanted to add in something else, like the combining knowledge. So I'm a physiotherapist, and the way I look at these issues, like how can I capacitate someone to have an effective cough? So there is an area of intervention for physiotherapy, which is respiratory care. And one of the ways for us to help people manage issues like this is also being able to learn how to really cough well and to be very productive and be able to take whatever is irritating out. So just keep that in mind. That's also something that people can, a resource that you can go to.
Yeah, and I think actually having what we call a productive cough, where we can actually get rid of the material, is a big focus when you work with an SLP or a speech language pathologist. That's very good, and also your physio can probably address that as well with you. So that, again, coughing or choking on food or liquid is a key indicator. Another thing that happens early and often is people reporting issues when they're swallowing pills. And we call that pill dysphagia. And dysphagia is the scientific term that I will probably not use anymore in today's lecture, but swallowing issues when you're taking your pills. And from the surveys, people were talking about pills getting stuck in their throat, or pills getting having difficulty getting them down, or this one gentleman saying, I have to swallow pills by throwing my head back with the water. And I'm going to suggest that that's actually a real indication that maybe the tongue's not doing the work it needs to do. And that's a great reason to work with a speech language pathologist, because you can strengthen those muscles. When you move your head back like that, you're actually bypassing a lot of the natural defenses. Typically, your tongue works to keep liquids from going over the back edge into the airway area. And if you're moving your head like that, you're going to make it more likely that something goes the wrong way. And so I put this in early just because I wanted to talk about this. If you have issues when you're taking your pills and you're doing some pretty impressive maneuvers like that, maybe get rid of the liquid, get rid of the water, and replace it with a puree. Like an applesauce is a really good one, or something soft that you can actually put the pill in, or, take a spoonful and then swallow with the bolus, with the puree instead of the liquid. When you think about taking a pill with liquid, you have this really solid object with edges on it that doesn't really have any flexibility. It's the size it's going to be. You're not going to really chew it up unless someone actually reported chewing their pills, but you're not normally going to do that. And then you have a liquid that goes wherever it wants. It always follows the path of least resistance, and you're trying to manage that at the same time. If you take a little bit of applesauce, or you can mash up or chew up a little bit of banana or something like that, it makes it much easier, and it provides a much better way to get the pill down. You don't have to worry about all the heroics you're going through trying to get the pill to do what it's supposed to do. I will say that if you are someone who has a reaction with protein in some of your Parkinson's meds, you might stay away from something like cottage cheese or even yogurt, because those dairy products will have a fair amount of protein. I think, again, the easiest is probably a little bit of applesauce, but your mileage may vary. Whatever you have in the house will help. So another common thing that we see people dealing with is watery eyes and runny nose, revolving around food and meals. Now, People can have allergies. People can have postnasal drip. That's actually fairly common in Parkinson's and probably related to some of the autonomic issues that happen in Parkinson's. But particularly if you start eating a meal and you're starting to get a little bit of watery eyes, or you're getting a little bit of your nose is running a little bit of postnasal drip, whatever's going there, that usually means that those are the beginning of your body's natural defenses trying to actually address that. And then again, it's an early warning system. So you haven't started coughing and clearing your throat, but you're getting in a situation where your body's like, hey, something's coming close, and we're trying to protect against that. So those are another set of things that could show up that I would definitely consider talking to your doctor about, because this would be something that might be related to a swallowing problem. This is a good reason to get a referral. And I'll add into that is if you take a sip of liquid and after you're drinking, you have what's called a watery vocal quality. You can literally hear the water kind of percolating while you're using air to talk. That means that the liquid isn't necessarily in the airway. It hasn't gotten into the place where it really shouldn't, but it's close. It's right above there, and it has a lot of danger of perhaps going into the airway in a way that could be bad. It could cause pneumonia. It could cause other issues. So again, those are the top 4. Those are the big ones, and I'm just going to review them again just so that you're keeping on top of this. Coughing with liquids or solids. Liquids is more common, but solids, especially something that maybe breaks off and is a little bit crumbly or maybe scatters a little bit, that can often trigger a coughing event. Difficulty with pills. And again, it's one of those things that's almost so common that it's one of these early appearing things, like the loss of sense of smell. So those are 2 pretty common ones. And then if you're dealing with watery eyes, watery vocal quality, or a runny nose, again, that's telling me that you're probably having something getting into the area that triggers the warning from your body to say, hey, there's a foreign object getting close to our airway. Do something about it. And then usually doing something about it means we start coughing, but sometimes it's not quite to that level and you just have the precursors. So those are really basic, obvious ones. And now I think I'd like to talk about things that are maybe less obvious, so more subtle indications of a swallowing problem. This is something I'm sure you encounter this a lot too. People complain of having a long meals. The meals are slowing down. They're taking a lot longer. It takes a lot more work. People are getting fatigued during meals, and that can really tell you that maybe it's taking more effort and more energy and more work to get through a meal. Now, again, that doesn't always have to lead to a swallowing problem. It could be just how you're getting food from the plate to your mouth. It could be something related to posture or other events. It could be related to the amount of distractions in your environment, noise and whatever. But overall, if you're having longer meal times, it means one thing. On the one hand, it means that you're probably not getting as many calories in. And on the other hand, it probably also means that you're spending a lot more energy. And when you get done with it, maybe you're feeling tired and you need a break. Now, the easiest way to solve this from the speech side of this, I would say, would be to consider smaller, shorter meals, staying with nutrient dense. But then, Josefa and I were talking about this, and you mentioned.
No, I was saying when we're dealing with fatigue, if I'm looking at it from, okay, what do I do about the fatigue? I try to identify what may be the underlying cause of fatigue, right? Is it maybe sleep issues? Is it sleep attacks? So it can be so many different causes of that fatigue, right? And not only the fact that I'm taking too long. And then, so it's how, and that could on its own influence then the swallowing. So it's like indirectly, if I'm dealing with fatigue, extreme fatigue, that will affect how I'm swallowing and the amount of time I'm taking to have a meal. And then, there's tricks and strategies that people might refer to, like getting up more often. So instead of staying 1 hour in a sitting down position while you're having a meal, just getting up, maybe go get something, or just so that you increase the alertness. So your alertness to have less fatigue as well.
Yeah, I think it's really common that if you start getting settled in and you're getting comfortable, it's really easy to kind of get a lower level of energy and start falling into that zone. So I like the idea of getting up and getting out and getting about a little bit. and then perhaps find some other ways of activity.
Obviously, it's like trying to find the cause of the fatigue, but these, when we say getting up, that's a strategy to deal with it. So, okay, so you have the problem, and now what can I do about it? Maybe just breaking down the meal, or even the simplicity, how I'm organizing the food. So there's all sorts of tricks that people can do, so they minimize, the chewing process as well, right? The size of the portions.
If you want to add on one more piece to that, because we were talking a little bit about diet in the past, is sometimes food that has a lot of carbohydrates or really heavy meat might also slow you down a little bit. And that's another piece to consider within there. So now another thing that we see a lot is unintended or unexpected weight loss. And if if there's a reason why you're doing a diet for whatever reason, sure, that's great. But if you are finding that you're losing weight and you haven't significantly increased your exercise, then it speaks to maybe you're not getting as many calories in as you did before, and you need to address that. And if you wait to when you go to your doctor, when you see the doctor on the 6-month schedule every year, or however frequently you're doing that, depending on the doctor, not just the neurologist, that might be too long. You might want to make sure you're tracking yourself at least a couple times in a month. Maybe you don't have to do it every week religiously, but it would be a shame if you were having this issue and you got 6 months down the road before you started realizing something was going on. So keep after that. Obviously, this is one of the reasons why physicians, when you go to their offices, whether it's your PCP or your movement disorder specialist, that's why they check that stuff. But you want to be on it before then. You want to make sure that you're taking the action. So that's a real key indicator. Going back into the survey again, this was very frequent. People were talking about all kinds of issues with certain foods. So if you're having trouble with what we call more complex textures, intact meats, lettuce was a real common one, apples, even stuff like nuts and rice and things like popcorn that scatter when you're chewing them and they break up into pieces. If you find yourself avoiding those things, maybe not eating them as frequently, or not sure you're interested in fighting that day, that's an indication that there's a swallowing issue that you could probably address with a speech language pathologist with some exercise and some meal choices. But typically speaking, things like this are more complicated for everyone. And if you're finding it to be a barrier, then that's a good reason to work with somebody. And when I say intact meat, I'm talking about a steak or a pork chop versus something that's been chopped up like a hamburger or a meatloaf, even better. And again, going back in a survey, someone was even talking about grape skin. So grapes, the outer layer of it, and I could see this exactly what they're doing. There's a lot of liquid there, so you're contending with this liquid, and then you have this hard kind of surface that is also a little bit stringy, and those mixed consistencies are particularly difficult. It's not unlike the pill. It's not unlike what we're talking about with the medication. If you have like a bowl of Cheerios where you got something crunchy that you have to manage, and then you have a liquid which goes wherever it wants to go, that can be a lot to manage if you're having any issues with your swallowing, because your tongue does a lot to hold up and keep liquid from going through the back of your throat. But at the same time, it's moving the food around and getting it in the right places so you can get ready to swallow. So, oops, did I take it one step forward? No, we got it. And that kind of gets to another part of this too, where we talk about residuals in the mouth. And residuals just mean little bits of food. And there's certain sticky things. If you're eating a bunch of dots, you might have, we're all going to have residuals. But if you get done with just a regular old meal, had something for breakfast, and you're finding bits of food pocketed here in between the teeth and the cheek, in this little, what they call lateral sulcus, that usually means that when you're getting ready to swallow, usually your tongue's going to kind of pull everything together, get it ready, and then it swallows a very cohesive bolus. But maybe you're missing some of that, and that's by itself just tells you that maybe you're not using as much effort and energy when you're doing the eating, and that's something that be strengthened. But the real risk is if you don't catch that, and then maybe you take a little nap, or you're not really attentive for a little bit, those bits of food which have protein and sugar and maybe some bacteria from your mouth, if those get back into your airway, they become a really prominent way to get pneumonia. If you have a bit of food in your mouth with some of the bacteria and it gets down into your lungs, it's dark and it's moist and it has this little bit of protein or whatever was in the food, it becomes a really prime way to turn into something more dangerous, and you want to be careful of that. One thing for sure is after you're eating, it'd be great to do a mouth check. If you can do some toothbrushing or at least rinsing, that helps a lot. But just make sure that you're not leaving any residuals, because it can lead to real complications. And if you're seeing that frequently, again, reason to work with a speech language pathologist. Again, another really subtle one, and I think that if you're, again, working with a good movement disorder specialist, they're going to be on top of this. If you have a couple of recurrent respiratory infections, so if you have a couple of respiratory infections that are coming on top of themselves more frequent than even once in a year, that would be something that would probably be an indication that food from your mouth is getting into your lungs somehow, and you need to address it. And that's, again, pneumonia is a very serious issue. I would say falls are probably the most serious issue that you always want to address in Parkinson's. I think pneumonia comes in very close as a second, because it has a lot of complications, and it's also very addressable. Now, drooling, you wouldn't think much about this because it's just something that people often report, and they often have complaints about it because it's it's embarrassing, and it's kind of a nagging problem that continually needs to be addressed. But actually, if you have drooling as one of your symptoms of Parkinson's, you're automatically, according to the research, at a higher risk of having a swallowing problem. And it's just a matter of these kind of issues tend to cluster, and they show up together as kind of a package deal, especially with people with certain kinds of Parkinson's. And so if you're dealing with drooling, then that's something to tell the doctor about. First of all, because the doctor will have some tools to maybe address that. And actually, I went to a lecture just a couple of weeks ago with Dr. Faulkner, and he talked about the use of botulinum toxin, and it's really come a long way. So there are really great tools to address it in addition to the stuff we had before. But also, if you're dealing with drooling, you definitely know that you might have more risk for swallowing, which is a great reason, swallowing dysfunction, which is a great reason to work with a speech language pathologist. And one of the very early indications of a drooling is waking up in the morning and finding a little bit of moistness on the pillow. That's probably the early harbinger. Before you start seeing a situation where you have something in the corner of your mouth, you'll probably notice something on your pillow. And that's when they get aggressive about it. That's when you can do the most to address it. Esophageal issues are it's a whole other can of worms, really, in Parkinson's. And in the esophagus is this food tube that starts right about here and goes from basically where your airway ends. It's behind your airway. The airway's in the front, and it takes it all the way down to your stomach. And it's completely involuntary, which means that the autonomic changes, the automatic nervous system changes in Parkinson's that affect many other components of Parkinson's, can often affect the esophagus, leading to a lot of issues. And that could be, like someone was asking, particularly about spasms. And I think the spasms are, not hiccups, but something that is causing discomfort, as well as perhaps preventing food from getting where it needs to go. That could be partially autonomic. I would suspect that it also probably has to do with some reflux, but that's the kind of thing that you definitely want to talk about with your doctor, because it's going to be something to address. It's something for sure that's a little unusual. For most people, what you're going to find is that they're dealing with a situation where food feels like it's getting stuck down there, or it's not traveling very well. There was some individual that was talking about food or pills feeling like they're stuck down here rather than being stuck up here right where you're swallowing. And what's interesting about the situation with the esophagus is that there's a lot of nerves that refer up, and sometimes you can have a problem down low, but it'll feel like it's up here, and it just puts that sensation, that globus sensation, up higher. Related to this, and in combination with this, is gastroesophageal reflux disorder, or GERD. And this is a situation where typically the bottom of the esophagus, what's actually it's the upper esophageal sphincter, even though it's the lower esophageal sphincter, it doesn't get closed all the way, and it ends up letting acid get into that area, and it causes a lot of irritation and some deterioration. And again, reflux is very common in Parkinson's, and if you're having some indications of it, your doctor will have some tools for it. This is not as much work for speech language pathologists, but there are things you can do. You can change some of your eating habits, and it usually has to do with the size of the food and the size of the meals you're eating. But again, GERD is something that's extremely common in Parkinson's. It should be something that you're aware of and being addressing. One other thing with GERD, if you start looking on Dr. Google, is you'll see a lot of basic recommendations that we call reflux precautions, and those are worth looking at. So it's avoiding acidic foods like tomatoes and orange juice, and unfortunately coffee, and unfortunately chocolate. And then you can also raise the head of your bed a little bit, and those things can help in addition to dietary changes and whatever the doctor's got for you.
Yeah, so that's our list.
Yeah, these are off the beaten path. We gave you the 4 big ones, and we're going to change gears for a little bit. Maybe make sure we got everyone on the same page.
And so I think it's important that the key message of this talk is to understand that there are several signs and symptoms that you can look out that will help you identify a potential problem. And what highlights is then, if you think about now, how do people actually report this? So when do people actually report having issues with swallowing? And this is what came out from the questionnaires.
Yeah, and again, I think that it's good that you reinforce that. We want to make sure that people are keeping an eye out, keeping things on their radar for things like, oh, that they said that could be part of a swallowing problem. Good, go with that instinct and get aggressive with it rather than, the A to Z of what swallowing is. So I hear this so often. People talk about mucus in the throat, and again, we talk about postnasal drip. Some things are more autonomic and related to that dysfunction. You can always have allergies. But again, if that's happening in conjunction with meal times, that tells me that maybe there's something going on with your food that's getting to somewhere where it's triggering your body's warning systems to say, hey, protect me. Don't let this get into my airway. It's also very interesting to say if they choke, if they're not paying attention while eating. And Parkinson's do not. That's everybody. If you are trying to dual task, we do a lot of dual task work, and there are good times to dual task, and there are bad times to dual task. Like dual task on a treadmill, that's fraught with danger. And dual task while you're swallowing something, that's fraught with danger. And so not paying attention, or maybe having too much distractions, whether that's noise or people or visual stuff, that's a good reason to have that happen.
Simply putting the food in your mouth and then turning around to talk to somebody, right? So the position of your head is automatically changed. And so that usually is a cause of stress.
For sure. Especially because, Parkinson's is generally going to start on one side and go to the other. And that means that turning your head, you could absolutely trigger something where you're pushing it to a side that's not as strong. Choking. I'm just going to read through these because I want to make sure that you get to how many people said choke. Chokes more frequently. Occasional slight choking on saliva. Choking tends to choke when drinking water and having trouble swallowing pills. That's textbook. Multiple tries to swallow, and then choking and coughing while eating. And then it looks like this one, pills catch sometimes, so they're getting stuck up in this area, and it clears with drinking water. Before the diagnosis, might happen with food and also with liquid, but it doesn't seem like it's been happening at all with food since the medication starts. And again, I want to reinforce, Parkinson's is insidious, and that just means that it's subtle and slow and leads to gradual bad effects. And that's what you're trying to see. And so if this individual particularly, they used to have this problem a little bit before, maybe they had some pill swallowing issues before, that's an early warning sign. And like a lot of other stuff in Parkinson's, it might predate your diagnosis.
And I think it also brings up a good point, which is the person having the meal when they feel that their medication is working best.
Big time.
Right. So as you can see, it's like if we don't have the medication working, that's usually classified as an off period. but not necessarily. The person's not is feeling more foggy, more tired. The fatigue, for example, is so identifying. When I said earlier, we have to identify the causes, right? Why is the person so slow when they're eating? Is it exactly at the time that you're about half an hour before you take your next medication? That's usually, or the half an hour after, right? That interval of 30 minutes before and 30 minutes after is usually a period of time where you have less effect of the medication, less benefit of the medication. And so that will bring your Parkinson with more challenges, right?
Yeah, absolutely. The medication is particularly effective for movement-related components of everything, from walking and gait and handwriting and all that kind of stuff. Well, there are movement-related components of swallowing. So the motor parts of swallowing, they're definitely influenced by medications. And so if you're in that zone, and you might even want to have some foods that are nice and easy to eat if you're in that zone, but you need something to eat. Yeah, let me go to a couple more. Yeah. Again, it was so helpful, and we want to thank everyone who replied to the survey, because it really helps us. We have so many
Choose
things we
your
can
words,
talk. Yeah,
right?
we can say, let's cut these 10 slides and really just focus on this part of it, because it's really helpful. So this individual here saying, I often get a running nose soon after I start eating. That's a pull up my chart and send that to your doctor. Give them that little note that you have enough characters in my chart to let that happen, and they'll want to address that, because that's, again, telling me that the early warning system's coming online. Occasional difficulty swallowing pills, and again, that could be in a situation where when you're more fatigued or you're not as alert, maybe that's more difficult, or maybe it's just the time of day or whatever it is. Sometimes it seems that whatever he swallowed goes in the wrong direction, starts coughing, and it's either with food or saliva. And again, very common. So food's a little more dangerous. Saliva, though, again, this goes back to the drooling. When someone with Parkinson's is drooling, they're actually not producing any more saliva than they did before. You know, the term sialorrhea is the medical term, and it actually means excess saliva. It's actually not correct. People with Parkinson's have the same amount of saliva, but just like you don't blink as much as you do or you did before, you're not managing that saliva actively. And so your same situation. If it's coming out the front, it's drooling. If it comes through the back, now you're coughing. You're having these little episodes. And so it's something to address with the doctor. This one here, I want to be real clear. This food gets stuck, and sometimes I have to use the Heimlich maneuver to dislodge the food. So that means you're getting behind someone. If you don't know how to do this maneuver, boy, talk with a therapist that you know. I mean, you can certainly go online, whatever, but there's a lot of anatomical differences, and you might want to get some hands-on experience how to do it best for your care partner, or maybe how to do it for yourself if you're not around a care partner at the time. But that's a pretty serious issue. That's actually, as a speech language pathologist, that's a real choking event. And this person probably worked with a speech language pathologist, because now they're taking smaller bites and they're chewing more thoroughly. And I want to get to this thing I just pointed to, because this is where medical terminology gets in the way of human terminology, because everyone says choking. You know what?
Yeah, we were discussing that earlier. It's like, wait, when people complain to me as a therapist that they're having this issue, they always say they're choking.
Yes.
So, and then no, but that's not how we say it. I was like, that's fine, but that's how people say it. So how do we get to, if the health professional that you are reporting to is interpreting a whole different thing,
yeah,
and you can see how the relevance will be given completely different. So like, no, we want to capacitate and build, knowledge so that you can identify the right words to say, to be able to really transmit what you're going through. It shouldn't be the person with Parkinson or the care partner's responsibility.
No,
it should be the health professional should be able to
translate,
to know this, to understand how people are reporting problems. But you know what? If you know this and you can help yourself, even better. So if we can increase knowledge of the professionals and also the people with Parkinson and the families, better, right?
Well, and getting directly to that, because again, you hear choking all the time. We saw it in a survey probably 25 times. We saw it frequently. And again, in graduate school, they start, this is what choking is. And choking to us is something where food or a solid material in the airway gets into the airway and stops the person from breathing, blocks the airway. And that's where Someone in the chat says that Heimlich's no longer in use, but you have to do something to clear that out of the way. So that's a choking event. Not that people who wrote choking were wrong, because again, your doctor should be smart enough to translate. What we talk about in speech language pathology land is we talk about penetration and aspiration. And all that means is that something that shouldn't be in the area near your airway. So you swallow, your food goes down, this piece of skin comes down at the epiglottis, and then it basically shoots it to your esophagus. It goes down to your stomach, and that's a good swallow. But if for some reason a little bit of that food gets past that epiglottis, or maybe the epiglottis doesn't come all the way down there, and now you have a little bit of food in the area above your airway, now we have a situation where it can penetrate, it can get into the areas above the airway. And then if it gets into the airway itself, that's aspiration. So it's just one of these things where it's gradients of the same thing. Again, if someone comes up to me and says, I'm choking when I drink liquids, I'm not gonna be like, oh no, that's not choking, you know. But you got to realize that there's a distinction that sometimes we have to re-educate people on. Anything more on that? Because I think it's a good one.
It's a severity, right? It's the importance that the professional will give or not to the topic. So
choking on a solid piece of food is a 5-alarm fire series event. That I want to address that immediately. Now, if someone's getting liquid into their airway, I also want to address that pretty quickly, but one's life-threatening. So, okay, so now we're going to get a little bit into how we manage things, and this has been really interesting. This comes back from the survey again, because we talked in the survey about whether or not you've worked with a healthcare provider to address this, and it was about 50-50. So we had 18 people who said yes, and then 18 people who said no, and then there's a couple more people who said, oh, you know, I have a therapy order for dysphagia, that's the actual real term there, or strengthening your tongue. So that's probably someone who worked with a speech language pathologist. So I'd say it's about a 50-50. And I'm just going to say that given the prevalence, given how many people are probably going to have a swallowing problem at some point with Parkinson's, this number should be a little higher. You should probably all have a long-term relationship with a speech language pathologist. And sometimes they might be working on your communication and the cognitive components of that, or they might be working on this, just like you should have a long-term relationship with your physiotherapist and other professionals, a psychologist, an occupational therapist, and social worker. So these are the kind of things where it's like, if you looking at these numbers, we want to see more. We want to see more people talking to their doctor and getting the referral. And hopefully you're armed with some early warning signs so you can start saying, hey, I saw this and I didn't think of it before, but now I definitely want to ask the doctor next time. So how are we going to address this? This is a very nice, great graphic from Josefa, very WHO. It's great.
Yeah, the focus of the talk is really to help you identify the problem.
Yeah.
And now overall, what can you do about it? Where we can go into a lot of deep, it would be another talk, but we want to give you a big picture about what you can do about it.
And actually, we have done a couple of previous talks where we hit on different parts of this topic again. So some of this has been covered before, but not specifically here, where we're talking about how to identify it. That's why we like this lecture. That's why this is one's a little different. The first thing is that you should probably start working with a speech language pathologist. You should at least get an evaluation, and if they can identify a problem, they will find exercises that are specifically geared towards your situation. It's dangerous to do a one-size-fits-all, or I saw this on a YouTube thing, because sometimes things that are working for other situations don't necessarily work for you, because everyone's different. I mean, Parkinson's is that way, but people as well. And I'll get into a couple of those in a minute. Then you'll be looking at ways to make meal times easier. And again, we've talked about the on time. Josefa was mentioning that before, making sure that you are at the point in your medication cycle where you're going to have the best performance. And it might help to focus on your posture. Sometimes there's adaptive equipment. You know, if you're having a lot of issues getting food from the plate to your mouth, you can work on that.
The most common thing that we see is people will complain about this. It's like the body is going to meet the fork instead of the fork coming to the mouth, right?
Yeah.
Because of the changes in posture and energy level. And so it's just being aware of that, because they said, oh, they're always correcting my posture while I'm eating. And that is ultimately what's happening, is you are meeting the fork.
Yeah.
And then it has to do with confidence as well, in terms about how you're sitting and how you feel the energy. There's a small detail that I usually identify, is the way people are using the fork and knife or the spoon, where the arms are very close to the body. So by losing that amplitude that everyone talks to you about, that we need movement in our arms, nice big movement. So because the movements are small, and that's why the head is going to meet the hand, because it's not feeling that confidence of lifting up in your elbow, for example, to take the food. But these are things that you work on in terms of movement, so that you can do that better.
And I want to build on what you're saying with it, because once you start moving forward to meet the plate or the spoon or whatever you're doing, you're putting your posture forward. Like, you're putting all the swallowing structures in a situation where they're now compressed. And when you think about swallowing, there's a musculature action that you're using, maybe the tongue to get something in place, some of the muscles that are coming in action there, and then the peristalsis later on. Then there's kind of a vacuum pressure, so if a muscle's not providing a good air seal with your lips or with your tongue. And then there's gravity. And so if you start changing the dynamics of the gravity by changing your posture in a more forward-leaning position, you're interrupting the natural order of things, and you're making yourself work harder. This gets back to the fatigue. So just real quick, I mean, we're talking about the specific exercises, and two ones that come up quite often is the use of a chin tuck when you're swallowing, and the idea is you would take a sip of a liquid, you keep it here in the mouth, and then you tuck your chin and you swallow, and that can be a very effective way to reduce the risk of liquid getting into the wrong places. So by not letting it just go in a natural, we're not doing a Mountain Dew commercial and drinking and gulping like that, but controlling that, you're taking control of the speed and the timing. And then by tucking your chin, you're forcing the epiglottis to provide better airway protection. However, in the research, when they were assessing chin tuck for swallowing for Parkinson's in particular, they found that many people didn't find benefit from it. And this is why, again, working with a speech language pathologist, and I mean one in person, who knows your situation and takes you into the radiology suite and does a modified, that's a much better way to approach that, because you don't want to just be like, oh, I'm trying it, and maybe it helps me, it doesn't. It can be contraindicated. And especially if you're doing that with a pill or something like that, you're actually making the passageway a lot narrower. So it's actually not something I would necessarily do with a pill, unless I saw it during an X-ray swallow exam. Using a straw is very controversial in our field. I'm a big advocate of using it, particularly with a chin tuck. But when you do liquid in a straw and the straw is coming into the mouth, you are automatically moving it way back to the back of your mouth and putting at risk for getting past your body's natural defenses. So there are people that are not on board for that, and I totally understand why. And the reality is, again, I wouldn't recommend for or against a straw until I saw it myself in a clinical examination. And that's why I'm saying, going on to Dr. Google or Dr. YouTube and seeing something and starting to apply it, just get a relationship with a speech language pathologist. It'll really help you. It'll be something that you can come back to over time as something crops up, just like you could with your physio. Now, generally for all of us, Parkinson's or not, smaller bites, smaller pieces, eating a little bit slower, being a little more mindful, those are all great recommendations. And you can find consistencies that maybe aren't quite as complicated, so that you don't have to work quite as hard. And things that are drier, like this chicken breast by itself, fairly dry. You might need some condiments to go with it. You might need something to give it a little gravy or something to make it a little easier. But you can always find ways to make the food a little softer and easier to handle. When we're talking about meal times, I think it's really common to be in an environment in mealtime where maybe there's a TV on or the radio, or if you're out at a restaurant or somewhere in a building with a lot of people around you, that can really have an influence. When I was working in different clinics, the first thing we try to do is put someone away from a lot of noise. We have them, they're towards the wall, or there's not a window right there where people are walking by. And you can kind of draw on that in your own environment. So getting rid of extraneous noise sources, extraneous visual content, and just focusing on eating can be very helpful. And
I'm wondering how many people are actually looking at their phones while they're eating. That's something I see often in coffee shops and restaurants.
I think we're going to find, about 10 years ago, we started talking about sugar as a carcinogen. I think we're going to find smartphone as a carcinogen at some point, but different conversation, not for today's lecture. But yeah, looking at a phone, you're automatically putting yourself in a position that's pretty bad.
Yeah. It was just to highlight what I said previously about, rotating the head when you're swallowing, and how that usually increases the risk of having a choking event.
Yes, I'm more focused on one of them has a salad and one of them has a hamburger.
No, that has nothing to do with the message.
All right, and then again, monitoring, and that's really the whole point of today's lecture. This is really why we wanted to have this discussion and not get too bogged down in the anatomy and physiology or the science. We want to just talk about what are the warning signs. When you start seeing these problems, this is, not this anymore. Now you go to the computer and you do my chart and you get your doctor's attention and you get a visit or you get a referral, but don't let it go.
And I think this slide might say it all. Unfortunately, we won't help the person that wrote this, but the idea is that we want to help people get the right knowledge so they can help themselves. And this places a very interesting question, which is, should I be, because there's so much information, right? There's so many talks. I'm like, am I just going to go to every talk now about Parkinson, thinking that I might have the problem? I can understand how overwhelming that might be, and we have to find better models for people to get education. I would say we have, in terms of science, identified key areas where people should keep informed, like balance, gait, falls, and yes, swallowing as well. So I think everyone here, obviously, if you hear it, this is an important problem for you, and hopefully we can help more people understand that this is something that you want to monitor. And I totally understand that people can't go to all the talks and all the problems because the Parkinson is too complex for that. You do nothing else. But so the idea is prevention always helps you control any problem better.
Well, yeah, and also by not getting into all of me pulling all the slides with the sideways shot and you can see all the swallowing, hopefully this is not too scary or intimidating. We're really just trying to keep it pretty straightforward, see these things, talk to the doctor, and we're not trying to make this into a boogeyman in any way. So hopefully maybe this person, because everything will be available on the IPMDC.org website along with the slides. So hopefully maybe they'll come back to it and check it out. This is an interesting one. Just the last one I'm going to really get into here, but this person wants to figure out how they help this person overcome the difficulties so they can take their pills more effectively. And this person's actually chewing the pills into powders before swallowing. Again, this is something where I would definitely be working with a speech language pathologist first to see if there's ways you can improve that. But then getting back to some of the other things we talked about, you could probably crush pills if you need to, put them in puree, that certainly helps. There are certain formulations of medications that might be better or worse, and the doctor will know those. I'm not going to get into the medical stuff like that. I
want to highlight something, John, at least in my country.
Yeah.
The neurologists don't favor so much, unless it's really necessary, the smashing of the pills, because that means it really changes the way it's going to be absorbed.
Yeah.
So I would probably discuss it with your neurologist, but as I said, this is something very specific to clinical practice here.
Well, and especially she's speaking to a fast release Cinemet, right? A regular carbidopa-levodopa, but even that does change the dynamics of how fast it gets absorbed and when peak dose is in there. But if you're taking any kind of extended release or slow release, absolutely, you're going to change the dynamics of that, and that would be bad. That would eliminate the benefits of taking a controlled release formulation. So good point, and absolutely right on the money. And even then, if you would, that's the situation, you should have a conversation with the doctor, because taking like vitamin C or something like that could actually do that as well.
It always comes out to optional.
Yeah.
and the option is not taking, right? So you have to take it.
Yeah.
So if that facilitates you to taking the pill, then it's more important that you take it than the affected. But you can probably negotiate the dosage or something like that with the doctor.
And start looking at patch formulations or dispersibles or other versions like that.
One of our wishes is hopefully this was not a scary talk.
Yeah.
Because it can be a scary topic. I know how much it impacts people, you know, I'm going to use the word choking. Every time you go into the fear of eating because I'm going to have a choking event. And so hopefully it's useful information that you can use just to identify the problem, and there are ways to bypass it. So hopefully it's a positive message.
That having been said, now we have a couple minutes to open the floor. If anyone has any specific questions or things we can clarify, you can just unmute, or I mean, you can put it in the chat too, but you just unmute. Anybody have anything they want to ask about?
What did you say in regards to I missed it. The taking of, say, Ritari, the time the
Controlled release
pills instead, because I'm going to switch to Ritari soon because to avoid the off times. What relate to choking?
Well, okay, so Ritari is a controlled release formulation of carbidopa levodopa, but it's a special one actually because Ritari, I can say this to older audiences because I remember this commercial when I was a kid. If you remember the Contact, it is a commercial where they pull the pills and all the little balls popped out like that. If you remember that Contact, the cold medication in the 80s and whatever, that's what Ritari is. It's all these little balls of different size and different levels of coating on Cinemet. So that one actually won't be infected, but most controlled release formulations of medications basically take the medication, the active ingredient, and then they put a waxy tablet in there, and that slows down the breakdown in the system. So if you crush it, then you basically negate that. So Ritari won't be part of that, but many other ones will.
Thank you.
Yeah, no, that's a very good question. And a lot of people have had very positive benefits from Ritari for that reason. So it's a good choice.
Yeah, because the tabs give you the peaking where you get this rush an hour later, and then it just goes downhill, and then you're waiting for another hour and a half in an off period. If you get the same benefit over to spread it out over a 4.5 hour period, why wouldn't you?
It's a significant improvement on Cinemet CR, just because, again, Cinemet itself, levodopa doesn't have great bioavailability. So when you start making it harder to get absorbed, not great. But that's, again, Ritari has been a nice step forward. And I think, again, a lot of people have benefits from it. And it's one of these ones specifically that they say you could, if you needed to, you could open the capsule and put it into there. But don't do that unless you, again, I'm gonna stay with talk to your doctor first, but Ritari is kind of exempt from that precaution for that reason.
Okay, thank you, John.
Sure, no, good question, very much.
There is a question in the chat which I think is quite interesting for us to brainstorm about, which is how to help if drooling does not seem to be a problem to the person. So it's like how to help someone deal with the problem if they're not recognizing it's a problem. That's what I'm understanding from the question. Because all the strategies that we have is based on changing behavior, is us suggesting that you swallow more often, that maybe you have a handkerchief or something. John can comment more on what we can do for drooling. But you have all these strategies that people might teach you, and then if the person doesn't recognize the problem, they don't serve for nothing, right? So the only thing that comes to mind is I hope that the person is listening to the talk and can get more education on the fact that it might be a problem and that it should be dealt with. That's the only thing that comes to mind.
Yeah, it's definitely a higher risk because you're having more saliva. So again, if it comes out the front, that's drooling, but that same bit of extra saliva that's not being completely managed also has the risk of going down the back into the airway, and that could be the pneumonia. So that's why whether it's from a lifestyle perspective, it's not something that's bothering you, it is something you might want to address. And she's talking about the mainstays of how we would address drooling with awareness and attentional-based techniques. But again, I in the past 6 or 7 years, the use of botulinum toxins in various forms has gotten a lot better, and there are a lot of ways to address drooling that is as simple as going to the doctor for a visit where they do a couple shots, and it will address it for 12 to 16 weeks. And again, I got to hear Dr. Faulkner wax poetic on the only FDA approved formulation, Xeomin, although they use all of them, but Xeomin's the one that actually got FDA approved for drooling. And it says to me, as a speech therapist, I would very much consider that, because the techniques I'm going to use are going to make you have to focus on things and attention. And so if you can address it that way, it would be a very positive way to do it. And just to the person that we're talking to here, it will lower your risk of other swallowing problems and getting pneumonia. And that's why you want to be aggressive with it. All right. Thank you for joining us, everybody. Have a good evening.
Thank you.
Good night.